So no, I think there's a lot of parallel activities that are going on right now. And so we want to highlight a number of those and really just highlight a lot of the work that Regenstrief's doing under the auspices of the Addictions Grand Challenge, which is a large initiative for Indiana University. So I'm going to talk a little bit about some background and then have Katie dive into one of the important kind of data-driven and prioritization efforts. So really identifying a need, we're all familiar with the addictions crisis, but I think from an informatics perspective, we look at it as kind of understanding that the data needed to characterize and monitor some of these, crisis spans a pretty wide spectrum. We've talked with a number of people who are focused on efforts in the clinical spectrum, efforts that are focused on the policy spectrum, workforce spectrum, social and determinant spectrum. So really, there's a wide range of data that needs to be accessed and cultivated to be able to support the needs of the researchers across the campus. And so the good news is that we found is that there are a lot of actual data resources out there. We have countless resources here from a clinical perspective, but there are actually a lot of social determinants, data resources out there, policy data resources that are being put together. So that's the good news. Ultimately, the bad news is that, that data is largely siloed. There's really no unified process that exists to integrate it or really gain access from a systematic perspective. So really our vision with the Indiana Addictions Data Commons is to foster improvements in health and innovation by creating a state-of-the-art common data resource that'll serve as the data core and information hub for addressing the addictions crisis. And so in order to do that, we want to make data available, comprehensive data, commonly accessible data available to physicians, researchers, and public health and policymakers in order to effectively characterize, address, and monitor this crisis. So again, Katie's going to talk a little bit about some of the efforts to identify what data is necessary and how we put some priority behind it.
So as Dan mentioned, there is a lot of different data possibilities. So we took sort of the first pillar, and I think you'll pick up, we divided the work in the IADC into 3 pillars, sort of data, governance, and architecture. And you'll see it kind of play out here in the presentation, but I'm specifically working on the data side of things. And the first question is, well, what data? And so we started with a literature review, and we looked at the national landscape. What types of social determinants data are people pulling into publications? What are they publishing on? So we identified, it was actually 2,401 abstracts that we looked at, which we narrowed to 617 articles where we thought there was a possibility that they have combined a health outcome with some form of a social determinant type item. So something external impacting on a health outcome. Of those, we kept 178 for what we've called kind of a synthesis. And I think the big output of this, which has really helped with our prioritization, was we grouped them into 7 different categories of social determinants. So there are so many different types of things that impact you on a daily basis. And we needed a way to structure those to make it somewhat manageable in trying to figure out what data to pursue. So we started here, and you'll see we have it broken down by 7, and then started plugging in example measures of those elements based on what we were seeing in the literature. I'm not going to go into detail on this, but I will say we extracted out a lot of data elements. The health outcomes predominantly came from EHR data. A lot of the outcomes were based on utilization, and a lot of it was at the aggregate level. So there's aggregate, which is like community level or some higher level up, and then there's person level data. And a lot of it was at the aggregate level. My theory would be that that's because that's what's available to most people. But I can, if anybody wants to dive into that, we're happy to put it out there. We do actually, we got a request for revisions on a publication, so we're hoping to get this published soon. So the next step was to look at the campus landscape. So we looked at the broad US, but we have a campus to support. And so we went around, and Dan and I went all over campus, talking to people, phone calls with Bloomington. I was joking, this map actually denotes 2 things. There's not enough dots, first of all, I got lazy and stopped. But there is so many people on this campus and in Bloomington working in this space or similarly in this space. And so this map is you are here, here, and here, which is the researchers, and also how Dan and I felt for the month of June, July, as we ran around campus having all these conversations. So we interviewed each of the Grand Challenge Phase 1 awardees, which included people, as Dan mentioned, from the policy side of the shop to basic science. We had great conversations with people who are early on in like mouse trials, but the next step's going to be human. And so that's a great opportunity to say, okay, well, what are we going to need to support this next step? So we interviewed, and then we interviewed campus stakeholders, other people we think were working in the space who might have something to add to the prioritization. So we took all of those interviews, we synthesized them with the 7 buckets that we created in the literature review, and we ultimately created a prioritization table that was high priority and then ease of access. And so we could start looking at it and say, everybody wants this. So like criminal background is an example, but it might be kind of hard to get, right? And so we could start picking off low-hanging fruit off of that prioritization, and then also start putting our efforts into the things that are high priority, but might take a while to break down the barriers to actually get access to. So that led us to data. So we do have some data available through the IADC now. First of all, there is a connection to IMPC, which I know you all are well versed in, but you can combine these data with the data from other sources to get to the social determinants. The first real big person level matching we've undertaken was working with the Management Performance Hub, which is the state. I think they presented a couple weeks ago, so you might be familiar with, or at least were mentioned a couple weeks ago. They are sort of the clearinghouse for the state data sets. So they have access to the Homeland Security EMS runs. So we were able to do a patient level linkage for a cohort we created as a test. It was an emergency department cohort to say, what's the matching, and we're working through that process. But we got back EMS records. So it's the run, it's medications that were administered. So for an opioid cohort, that includes Narcan, which has previously been a little bit hard to get to. It includes the symptomology. Why was the EMS called for? We've also been working with the Polis Center. Many of you are probably familiar with them. They do provide data sets, but they also provide geocoding services. So we geocode all of the IMPC addresses, and then those can be linked to other data sources that are coming from groups such as like data.gov. So data.gov is a API or website for a lot of the federal government data sets. So we've pulled down already the American Community Survey data, which is the surveys that are done in between the big census. It's run by the Census Bureau. We've also pulled in the Food Atlas research, which gets to food insecurity and access to food. And those are done at census levels, right? So like census block is usually kind of the popular one. Because we have the geocoding, we can actually start matching up what's happening in that person's neighborhood. We recently also downloaded the Eviction Lab data. There's a group out of Princeton run by Matthew Desmond. You might know him. He wrote a book called Evicted. He's running a group that's done some pretty amazing work collecting eviction data across the nation, including Indiana. So we have pulled that data down as well. And we've pulled down from the State Department of Health the hospital discharge data, which is at an institution level. So cost data is something we have traditionally had trouble with from an IMPC perspective, but this gave us at least things like average cost per diagnosis code for this institution. So you can now start to get into, okay, at IU Health or at Eskenazi, if you're in the hospital for this condition, it's roughly this price. And then we're still working through that prioritization list. The Management Performance Hub has a lot of different potential data sets. We're prioritizing vitals, which would include birth and death records, education and workforce. The state and judicial data, this judicial and criminal data is a high priority for the stakeholders. And so we're really trying to work through how to get access to that. Public policy data. So Ross Silverman has a award through the Grand Challenge to collect all of the laws and policies that impact addictions in Indiana. And those will be grouped down to geographic regions. We've actually been talking with him about how to incorporate it from the beginning so it will flow nicely. But you'd be able to say, you know, what are the laws and policies that impact this person in Terre Haute or this person in Indiana or in Indianapolis, and gets into even like the little, I don't know, for those of you who don't know, like Speedway is its own little town. So you drive through Speedway, which is in Indianapolis, and you've changed a governing body over you. And so it'll be at that level. And then the CDC has similar public law data sets available on other addiction-based items like tobacco usage and all the laws that impact that. So we're going to go get those as well. They're publicly available. We've been working with the Indiana Business Research Center, IBRC. They're part of the Kelley School of Business. They also have some data sets available. I think the priority for that one is going to be kind of the built environment. So housing density comes up. How many people live in this particular census block or even down to this building? You know, or do you live in a high occupancy dwelling? And because that might have impact on your health from a stressor or what you're exposed to. And then one of the other things we've talked about doing is trying to get to these personal levels of insecurities. Can we utilize technology that we have here at Regenstrief, such as the natural language processing, to try and start extracting out and making some of these data available in a more structured format? You know, have you indicated in a note that you have trouble finding food? Have you indicated you have housing security issues? And so those are some of the priorities for the next 6 months to a year. So it all sounds great. We have all this data, but unfortunately, it's not quite that easy. There's not just a button you hit that's like data flows. And so Dan's going to talk to you next about governance.
Yeah, I only have one slide, and I don't think this probably does it a justice, but obviously one of our work streams that's essential to our success is how we organize and structure our governance. So I did want to take a little bit of time to say, you know, early on, understanding that, you know, certainly Regenstrief is a steward of clinical data, but we're trying to bring in much beyond that scope, and that we need to have kind of a systematic and really, you know, a good approach to how we govern this data and this tool. And so we knew we needed to form a governance council early. And so we try to meet quarterly or so. And so one of the tasks that we developed out of our governance council was that we need to first develop a charter. We really wanted to put down on paper the purpose and the vision, guiding principles and the goals and objectives that we knew we all needed to adhere to as this tool and resource begins to expand and evolve. I think probably simplistically, the key objective is just how can we develop the processes and agreements that need to be put in place between these organizations to enable data flow and data use. And some of the committee members that we have are largely representatives of our data partners, but also some individuals beyond that. Folks from the Management Performance Hub, IBRC, Indiana Hospital Association, Marion County Department of Public Health, IU, IHI, HC1, Polis Center, and Regenstrief. So again, we could talk a while about governance, but just understanding that it is its own work stream that is essential to understanding how we all get along and can agree on kind of what we need to do to enable data access. As far as the actual capabilities of the IADC, and really when I think of capabilities, I think about this kind of in twofold. One from kind of the informatics capabilities, how we actually store and integrate data, and then how that translates to those who need access to the data and the data requesters or the clients, so to speak. And so really what we came, you know, some high level principles of what we knew we needed to be able to enable from a data architecture and storage process was really a scalable and flexible ETL process to ingest a number of different types of data resources. Working with external institutions, we knew not everything was going to be able to be transferred in the same way. So we built out some capabilities to have a pretty flexible ETL process to ingest that data and ultimately capture that data. As Katie alluded to, you know, one of the primary goals, I think, of this too is not just to pull in data and have it live in isolation, but rather enable linkages between these types of data sources. So we know we're going to be getting data at a granular level in some cases, very person specific, in which case we can leverage technologies that Sean alluded to and algorithms in terms of patient matching to be able to integrate some of these data sources at a very granular level. Other types of data sources are going to be available at a more aggregate kind of geographic level. So we need to be able to have the processes to be able to integrate those types of data sources as well to kind of that lowest common denominator. And probably one of the biggest challenges here is that, again, we're bringing together different types of data that were never necessarily meant to mingle. So really trying to leverage a common data model in our approach to storing these types of data, and how we have kind of a systematic way to extract certain types of metadata from each of these data sets as well, so that we can convey, the capabilities of what's in this data set to our stakeholders. And so how this kind of translates to an individual who might be requesting data is really that it allows for very cohort-specific data pools that integrate data from various resources. You're going to have the ability to link these data sets by the individual person or geographic location to the extent that governance allows. And really one of the tools that we're developing that will be an external tool, external-facing tool, really it will be an IADC portal that will allow users to scan some of the metadata about these data sets to get a better understanding of what actually exists in these data. That it's, something as simple as, or as complex as the ACS data, it's very vast. And so we're trying to come up with a way that we can effectively characterize metadata from each of these data sources so that you can have a very good understanding of what data is available, how it can integrate with other data sources, and important things like, the timing for which it's available, the geographic scope, the granularity, and things like that. So I do have a couple screenshots available from a tool that we are developing that will allow you to access some of this. So as far as the IADC portal, we've got a few different ways in which a researcher could interact with potential data sources. And so one is really a guided search. And so this is a pretty broad way to start searching. And we view this as kind of for the researcher who doesn't quite know what they want yet, or doesn't quite know what data is accessible. So we really kind of pocketed these data sources in terms of, American Community Survey, INPC, so you could click on those and drill down a little bit further to understand what data is actually accessible through there. For the individual who maybe knows a little bit more of what they want to look at, we can have a targeted search that allows you to search specific elements. Maybe they're interested in, I want to be able to align a certain diagnosis code with household income or something like that. So maybe they could search those terms and get a little bit more of a targeted search as to what data can be accessible. And so I think a new feature within the IADC portal that I think is pretty cool that has recently been rolled out is a way to geographically represent some of these data sources to understand how they overlap with one another. And so this is an example of, we've got a node here for EMS data organized by zip code. And so you've got a total number of EMS runs that took place in that zip code. This blue, I can't highlight over it because this is just a screenshot, but would be American Community Survey data, which is organized in a geographic location, not quite like zip code, but you can get a sense as to what that overlap looks like from a geographic perspective if you're looking at different types of data sets to be able to integrate. So to give you some context, some example collaborations that we've been working through the last several months or so, it's actually with one with Titus. I don't think he's here today, but he has an Addiction Grand Challenge Phase 2 award. And so we're working with him and a couple investigators from SPIA, Brad Ray and Evan Lauder, to link a data set that they've created that has about 2,000 or so overdose deaths within Marion County. They've put this data set together. They've linked it with other sources of data, EMS, PDMP, Marion County Coroner's Office, and jail. And one of the things that they knew was lacking was a sufficient historical perspective of prescribed meds. And so we quickly kind of raised our hands and say, well, it sounds like that would be a job for the INPC to be able to link that data and fill in some of those missing gaps so that they can kind of examine some visual typologies for different types of overdoses. Another pilot project that's in the pretty early stages at this point, but we've had some interesting discussions with a faculty member at the IU Methodist who runs the chemical dependency treatment program. Essentially, there's a treatment program through IU Methodist that graduates roughly 2 to 4 patients per week from a 4 to 6 week program. I think there's probably about, maybe 75 or so individuals that they have. And a challenge that they have is that, after they leave this program, they don't really have a great systematic way to capture outcomes. And so what we want to be able to do is link those individuals not only through the INPC to capture 6-month outcomes that might be emergency department, recidivism, drug screens and information like that, but also be able to link this with other data sources that we have available, such as EMS runs, vital statistics like mortality, and ultimately, arrest data and criminal data and things like that, which would be important indices for tracking these people who graduate out of these treatment programs. So I think those are a couple interesting projects that maybe give a little bit of context as to how these different types of data could work together. This wasn't so much a research project, but a project that Katie alluded to earlier that I wanted to highlight because I think it has, is the early stages of, I think, a lot of interesting capabilities. So we're obviously working closely with our partners at the state through the Management Performance Hub and understanding early that they have a lot of very unique data assets, everything from educational information, workforce information, EMS data, all sorts of things. As Katie alluded to, they're the data hub for the state of Indiana, and they have it in very granular detail. And they make a certain amount of it public via a very cool data hub that they have on their website. But really that's all de-identified, and really we wouldn't be able to access that and really make use of it or integrate it with the data that we have. And so understanding early that there's a lot of opportunities with the data that they have and the clinical data that we have to answer some really interesting questions. And so what we wanted to do was kind of have a pilot project that would be able to enable reproducible processes to link persons derived from INPC with persons derived from their database. So we could potentially tap into a number of different data sources that they have. And then once we're able to make those links, how do we actually enable a process to transfer that data back and forth? So as Katie alluded to, one of the, we thought about this, how we'd go about this. They obviously have emergency medical service run data. We were thinking about what would be a population that overlaps to a certain degree with those individuals. And so we created a cohort in INPC that really took a look at anybody that had an emergency department visit over the last several years, understanding that there's going to be those overlaps. And so we identified some standard processes, and I think this links well with what Sean talked to about how we would link these patients. We identified several demographic identifiers: name, date of birth, gender, social security number, things like that we knew we needed to pull together from both of our sides. But in order to maintain kind of data integrity and not just sharing that protected health information, we wanted to be able to do it in a de-identified manner. So actually, MPH has co-developed a hashing algorithm and a matching process with a consulting firm that they work with, and they provided a tool to us that we actually were able to run our data set through. It hashed all these identifiers that we had in alignment, and we aligned our formatting with them so that we knew we were kind of comparing like for like, and they did the same on their side. So ultimately what we're able to come out with after they matched these different data sets was a table that has a unique Regenstrief ID on one side that we know who that matches to on INPC, and a unique MPH ID on their side that they knew who matches to. So we have that mapping table that we can then utilize to share data back and forth, knowing who that population is that overlaps. And so that can actually, enable some data sharing. And so once we were able to go through a little bit of a couple processes, one was Regenstrief was actually vetted to receive access to an authenticated data portal that MPH has. We certainly had to sign some contractual agreements, but really what we were able to do was identify who overlapped with each of our data sets, and then ultimately make a request for that EMS data that they were able to send over to us with that Regenstrief ID tagged to it. So we are currently in access, do have some data from the EMS that we're able to do some initial linkages on with our INPC data. And I think that, kind of paved the way for some interesting opportunities in the future. So, just a quick overview of some of the linkage results. And this is certainly a work in progress, but I think what we were able to do was match several 100,000 encounters and individuals that we do have data from their EMS visit all the way through their ED visit and linked those through INPC. And so I think there's a lot of factors to consider before we make any conclusions that, one of the difficulties that EMS pulls from data from a geographic area that doesn't quite overlap the data that we pull from INPC. So it's difficult to understand what that denominator looks like and what we should actually have in terms of a successful match rate. And we're currently working through some validation steps to understand the logic that was used to ultimately define what was a match. And this is a little bit of a heat map that was generated by Jack and the data core to identify some of the areas where we've had more successful match rates than others. So I think that kind of is some interesting things to follow up on. So kind of, again, what I don't want to get too much into detail is, the numbers themselves, but rather, a pilot project that we've been able to do really to establish some reproducible processes to enable a de-identified sharing and linkage process between data from INPC and data from the Management Performance Hub. So I think there's a lot of opportunities there. So again, I know we've just got a couple of minutes left. Really, as far as future direction, we've been able to do a lot of work in these various swim lanes of data governance, technical development, study engagement, and data sources. And so we're going to continue focusing on those different swim lanes to be able to enable kind of a better and growing resource that we hope provides some value to the researchers here on campus and ultimately builds up to policymakers and things like that. So with that, I'll thank the team for kind of helping put together a lot of this content, and I'll happy to take any questions.
So great talk, loved it. One question. You talked about pulling data from different sources. What's the process for updating that data?
Great question. So, as far as we can, integrate it in a systematic way, we will be able to do that and update that in an automated fashion. Some of that, to be honest, with some of these publicly available data sources, a lot of them do have some pretty nice APIs that we can tap into. And so our ETL process does allow for that. Other ones, to be honest, we're pulling data sets down and uploading them in a pretty manual fashion. So I think that's obviously an area of focus to be able to do that in a systematic way. And I think that aligns too with how we represent some of the metadata available. Each year, some of these things are going to be changing. So we want to be able to convey the most up-to-date data. So I'm not going to say I have a foolproof plan on how we do that, but it is a major consideration at this point. Yeah.